In situ flip of upside down IOL, when and why? Right side up position, Z shape configuration of the IOL is the right position of IOL inside the bag. Suppose we are faced with upside down position, S-shaped configuration IOL position inside the bag. Should you risk damaging the corneal endothelium and or capsular bag to correct this? The answer depends on the type of IOL. It is multi-piece IOL or single-piece IOL. Here I'm going to discuss the two situations. Usually multi-piece IOLs are angulated, optic haptic plane is not flat and the eye could be in trouble. Correct position makes IOL vault backwards in the direction of posterior chamber for stability. However, upside down position can vault forward out of the capsule bag and moves into the sulcus. Upside down position can change the IOL vault, resulting in myopic shape and can cause pupillary block, angle closure glaucoma, especially if the pupil is dilated for routine exam. This patient has been operated for cataract in a couple of months somewhere, presented to me with severe eye pain, and you can see upside down IOL with optic, capturing and blocking the pupil and the rent in the posterior capsule. IOP was very high secondary to pupillary block. After controlling the IOP medically, patient was moved inside the OR theater. Here you can see a vitreous prolapsing into the anterior chamber with pushing the IOL anteriorly as it's clear after staining it with triamcinolone. Anterior vitrectomy was done through the posterior capsule rupture as it's clear. Now the posterior capsule rupture and the upside down IOL, the S shape, are very clear. I used dispersive OVD in front and behind the IOL to protect corneal endothelium and to prevent more vitreous prolapse respectively. Then holding the Sensky hook with right hand through the main incision and secondary mushroom instrument with left hand through the left side port to start flipping the IOL with raising the optic towards the cornea and to the left with the Sensky, while simultaneously opposite movement by pushing the optic posteriorly and to the right with the mushroom instrument in anti-clockwise direction as you can see. Then IOL is centralized with haptics inside the sulcus. Now washing out the OVD with myopic injection to constrict the pupil as you can see. Triamcinolone is re-injected again to be sure there is no vitreous in the anterior chamber, and finally stromal hydration of the corneal incisions. Patient on the next day, you can see the cornea is very clear with almost rounded pupil and normal eye pressure with 20-25 visual acuity. Here is the second case with single piece IOL. With absence of angulation, these IOLs have no risk of pupillary block glaucoma after dilatation because the IOL will stay in the capsular bag. In single-piece IOLs, upside-down aspheric front surface could result in different post-operative refraction from the intended result, along with losing the benefit of the lens asphericity. Reduced spherical aberration at night because of large pupil sizes. However, upside-down, the biaspheric lens won't have any optical problems because both surfaces are identical. And in situ flip of this single piece IOL, as you can see, should be done around the long diameter which passes through the haptic optic junction to avoid damaging of corneal endothelium, with coating the corneal endothelium with dispersive OVD along with well formation of the capsule bag with cohesive OVD. Then adjusting the haptic inside the capsular bag gently. Here you can see the patient on the next day. The cornea is very clear and there is no corneal edema. And thank you for watching.